speaker is Dr. Peter Hill. He is a consultant nephrologist and honorary senior lecturer, clinical lead of nephrology for PKD and clearance, Imperial College Healthcare, NHS Trust, Imperial College London. He is going to talk about an update on polycystic kidney disease.
To give a couple of talks and to hear about the experiences that I've developed at this hospital in West London called the Hammersmith Hospital. The clinical presentation of this condition. It can present in a variety of ways, in particular young patients presenting with hypertension or blood in their urine, perhaps with proteinuria or with a new end-stage renal failure. But in many patients, there's a family history of renal disease, and that's quite useful when thinking about screening. And we'll come on to part of the role of screening towards the end as part of it. And the liver cysts can be a real challenge, particularly in women. And I have a number of patients in my PKD clinic where liver cysts actually are the predominant problem, even though they're known to have a variation in the PKD1 gene itself. And it's likely that estrogen has a role as an epigenetic phenomenon in the presentation of PKD. Now, in most situations, the diagnosis of polycystic kidney disease is quite secure. And in this CT scan, multiple cysts are seen throughout the kidney. And if this patient were to have a kidney removed, say to make room for a transplant, or to treat an infection, they're often the size of an American football or a rugby ball, sort of reaching up to 25 to 30 centimetres in many cases. And it's quite astonishing to think that you could be carrying around a 10 to 15 kilogram mass in your abdomen. And in many cases, they have reasonably preserved GFRs, despite such profound anatomical changes. There are some life-threatening associations with polycystic kidney disease that we're aware of. Very aneurysms, you can see here in this angiogram of the cerebral circulation. There's an outpouching of blood vessels in keeping with a very aneurysm. This appears to be, this affects about 5% of the younger population, and maybe up to 20% of the older population with polycystic kidney disease. And screening of these is quite challenging, and exactly what to do varies from country to country. The PKD charity, with work in the UK, is suggesting that we should be really screening patients who we think are high risk, i.e. those with a previous family history or known to have a previous rupture. And that can be done with MRA screenings, that's MR angiography, at a 3 to 5 year interval. I think that there are certain high-risk populations, say like becoming a pilot, or that might mean that you would want to think about screening if you have a patient with PKD and that's their work. And there are some controversies about whether one should be doing this prior to transplantation or prior to anticoagulation. Rarer complications of cardiac disease, in particular mitral valve and aortic regurg, and diverticulitis, diverticular disease and diverticulitis are associations too. So quite a mixed bag, although the predominant presentation is of kidney complications, in particular urosepsis, hematuria, and sadly end-stage renal failure. So I'm going to spend a little bit of time talking about the genes, because I think that it's in the future, like AI that we've heard about this afternoon, understanding how the gene translates into clinical practice will be increasingly important, will become increasingly important. And the aim in the UK is to embed genetics into everyday clinical practice. So when you're seeing a patient with a potential chronic kidney disease that could be genetic in its origin, the interested nephrologist who's had genetic education from their consultant genetic colleagues can offer genetic counselling, put the phenotype together, and then send appropriate testing. Now, the PKD1 gene is a particularly complicated gene. It's massive. It's got 46 exons. The beginning part is where most of the coding sequence is, and there's lots of duplication. And that means it's often with standard Sanger sequencing can be a little hard. And it's also right next to the tumour sclerosis complex gene, and that explains why there's often an association with tumour sclerosis and PKD. As I said, it's a large gene, and it codes for a large protein called Polysistic. And we know that it's expressed in certain areas, the renal tubular epithelial cells, but also within the hepatic bile ducts and within the pancreatic ducts. But we don't know exactly what it does. We think it's involved in cell-to-cell interactions and matrix signaling, and we also think that it's related to tubergenesis. But exactly what Polysistic-1 does is not completely clear, and knockout mice and other models have not really given us a complete answer to this. But what we do know is we know a little bit more about PKD2, this smaller gene is on chromosome 4, it's much smaller, but has a very similar expression. And we know that this is involved in calcium signaling and acts as an ion channel function, really sort of in keeping with one of these ciliopathies, and when it goes wrong, it produces a phenotype that's similar to the ciliopathies. So why have I started to tell you about the variation? Well, I think that's because they're often unique to single families, which means that genetic confirmation can be quite hard. We've been running a program in the United Kingdom called the 100,000 Genome Study, and many patients and families with polycystic kidneys have been recruited to that. And I think when that data comes out, we'll have a lot greater understanding of the complexities of PKD, and we'll be able to have much more, and be able to validate various genetic variations that were found. The variations in the gene can be variable. They can cause nonsense variants, frame shifts, or splice site alterations, and largely something that truncates the protein production is bad for you. And that's why I think genetic testing will be increasingly important. So if you can work out which genes are associated with a poor clinical prognosis, screening for those or knowing what that gene and targeting medical care at those patients will become increasingly useful and a clinical benefit. So, in keeping with that, there's been a score called the PROPKD score that's been developed over the last few years that takes into consideration genetic variant, but also certain clinical situations. So if you have a gene that has a poor prognostic association, that's where the protein's being truncated, then you're given extra points. If you have neurological complications, in particular hematuria, then that procures a poor prognosis, as does hypertension, and sadly being male, it's worse for you as well. So that then it gets put into a scoring system, and this is how it comes out. If you've got a truncating mutation with urological complications in a man with hypertension to a young age, you really have got full house. And this is associated, this gives you a risk progression where we can then target patients to be put into specialist clinics and follow them through with even sort of seeing the low-risk patients, leaving them in primary care potentially, depending on your resource, and those with intermediate and high-risk cases being seen in specialist clinics. This certainly appears to have data from this work from this group published in JSON. You can see that if the green bar are the ones with a lower risk, with a lower score, have a greater probability of survival and not reaching end stage, as opposed to those with a high PROPKD score. And I'm finding it helpful in my clinical practice to calculate the PROPKD score if I can identify a genetic variant. It's quite helpful when talking to patients. In the large study, in the large group which have done most of the genetic analysis, which is out of the Mayo Clinic, about a third, just over a third, are associated with truncating mutations, and about 30% of the slightly better slightly better condition in PKD2. And if you do have PKD1, then there are certain associations that are more likely to develop large kidneys and have an increased risk of end-stage renal failure and early death. With PKD2, you tend to be starting to get renal disease in your 60s and 70s. With PKD1, it tends to be in your 40s and 50s. The other benefit of genotyping is about trying to, is that patients are now understanding that with pre-implantation genetic diagnosis, or PGD, the disease does not need to be passed on. So if you can find a genetic mutation using IVF technology, embryos can be created that do not have the abnormality in the PKD1 gene or the PKD2 gene, and then pregnancies can continue with no genetic abnormality. And that's quite helpful also in patients who want to have pediatric diagnoses, and also in transplantation. And so you can exclude, you can include patients in the family if there is no genetic variation identified. So with this, the sort of the pros of genetic testing, I think, are becoming increasingly helpful. But there are emotional and problems, in particularly with predictive testing in terms of insurance. In the United Kingdom, there's a moratorium, but no insurance company is allowed to use data from predictive testing to load health insurance. But I'm certain that as more people put their DNA into DNA databases such as Ancestry.com or 23andMe, the use of insurance claims from predictive testing that's currently that's outlawed in the United Kingdom will become may become utilised as the actuarists get hold of it. So one question that I think we ought to try and answer is, why is there such variability? I'm sure that many of us have had patients who have developed kidney damage at a young age, whereas other family members have reached their 60s and 70s and have only mild CKD. And I think this is where new genetic phenomena or epigenetics or modifier genes that can change the penetration of or the exposure to the germline mutation and then influence disease. In addition, if patients are taking toxins or develop an additional nephritis or develop pregnancy-associated illness, then renal disease can also be superimposed. And that's explaining why there's such variability. So going back to the gene, if we know that polycystin 1 or 2 polycystin 1 in particular doesn't have a clear role, how on earth are we going to work out how to treat this condition? Well, that's where we're then working out with biological science what else is happening within the kidney itself. And there are 2 or 3 pathways that I think that we should highlight. That once you have an abnormality in PKD1, you then go on and develop abnormalities in cytokine, there's an mTOR program and to also glucose metabolism. And this is where many of our novel treatments have come, by understanding the sort of cellular pathways that cause cyst development. So what can we do? Let's think about this in terms of the clinical application. Well, I think there are only a few interventions that are available for patients with CKD now. And I think the most important one is probably early intervention with hypertension. Now, the HALT data that came out 5 years ago, there was HALT A in early chronic kidney disease and polycystic kidney disease, and in HALT B, which was in CKD3, there was an attempt to see whether or not very aggressive blood pressure control helped. In the HALT A study, we looked at 1,000 patients, blood pressure control using down to 90 to a systolic of around 100 was achieved. And there were some benefits in terms of they had less albuminemia, their left ventricular mass was better, but they had no change in the rate of decline in the estimated GFR, and the incidence of hyperkalemia was a problem. In the in the whole B series, there was no difference to using dual ACE and ARBs in the management of hypertension and CKD. It was helpful, and there was an association with hyperkalemia again. It certainly has set the precedent that largely ACE inhibitors are the first line therapy for patients with PKD. So what's the next step? And I think that's where we're learning about this now, in terms of treatments that can slow cyst growth. And there are lots of areas where there has been intervention for this. So we know from the CRISP data from the Mayo Clinic that if we follow cyst growth in the blue line here, as with time, there's an increased risk of, there's an increased rate of cyst growth. There is a decline in GFR, and the cyst growth, as you can see around here, predates the decline in the GFR. And I think this is where we're starting to really put out the efforts in people into management. And that's trying to get interventions in early, prior to the drop of GFR, because the pathology has already caused ischemic and fibrotic change within the kidney once we're on that slope. Sorry, once it's not quite coming up. The size of the kidney is also important. We know that from the Mayo data, the larger the kidneys, the worse the prognosis. So clearly we need to be targeting cyst intervention, I think, based on this observational data from the cohorts, from these large databases. And what the Mayo Clinic has done is they have such a large group of patients, they have serial MRs, they've been able to type they've been able to sort of subclass and type the conditions based on total kidney volume on an MRI scan. And I think to take Dr. Ahmed's presentation, I think go with AI, I can tell you that my radiologist rarely can tell you a cyst size or cyst volume. And AI is much better, and I think that when we can automate this, it will be great, because I can get an automated MR scan telling me the volume. That puts them into the group, that comes into me, and I can then put it into the Mayo database, or at least interpret in a way that I think would be helpful in clinical application. But our problem with this is that we've got to disconnect between cyst growth and cysts rather than GFR. We haven't got a great deal of data to show that we're going to be doing much in terms of GFR, because most of our interventions have been done quite late. So what we have done, we have got 2 RCTs, both of which have been quite helpful, and I think we're now coming over the barriers of using cyst size to make interventions. So the first one was the TECMO study with Tolvaptan, and this was a randomized study on a 2-to-1 basis. Patients were randomized to Tolvaptan or placebo. And what we found in this study was that there was a slowing of there was an improvement in terms of cyst growth, so that there was a much lower rate. Sorry, there was a lower rate of cyst growth. And when one actually looked at the change in GFR, there was a non-significant reduction in the rate of progression. It seemed to slow decline from 3.7 mils per minute a year to 2.7. But if any of you use Tolvaptan, you know it has a profound effect. It blocks cyclic AMP, it blocks vasopressin, and therefore you get a profound diuretic effect because it blocks that. Vasopressin is also known as antidiuretic hormone. And patients who take the drug will typically drinking 3 to 4 litres of water a day. Not 5 or 6, some patients do, but most in the clinical practice that I'm seeing in Tolvaptan, they're drinking about 3 to 4 litres. And because of that, the placebo group were asked to drink plenty of water, and that may have influenced the results. But there is a reduction in 1 ml per minute. There were also some associations with liver enzyme abnormalities and problems with sodium, and as a result of that, regulation and prescriptions of Tolvaptan require monthly blood tests, and therefore you're medicalising patients who are taking the drug spectroscopy speculatively at this time. A second study, which was put together in order to get regulatory approval in the United States, is the REPRISE data, and again showed an improvement in slowing the change in kidney function. So it doesn't stop decline. We're still losing 2 mils per minute per year in the Tolvaptan treated group, but it slowed it compared to 3.61. I think that's where the potential benefits are. So with that data, the drug Tolvaptan has been approved in the UK for the use in early chronic kidney disease and polycystic kidneys, and we decided in West London to put one polycystic kidney clinic in the centre where there's the blue H, and you can see the number of hospitals that feed into our sector, and that takes about a quarter of London's population. Now, in order to do this, there had to be an interested clinician. I happen to have a doctorate in genetic kidney disease, so I thought that I was quite keen to take it on. And I took your multidisciplinary approach. We used a clinical nurse specialist who wanted to give CKD management, a pharmacist who could prescribe, and we had access to backup from the genetics team in order to offer genetic counselling and access for PGD if it was required. This meant that we promoted it in grand rounds, we used their charities to give their liaison and had education day, and we used a patient education seminar called Save Your Kidneys. And with this, we then pulled in patients with adult polycystic kidney disease from all of those other centres who are now coming into the centre for treatment. And they have formed their own peer group, they've formed their own Facebook chat group, and they all sit in the Friday morning clinic chatting to each other about PKD interventions, and what we can do has made us really think about other interventions, in particular management of pain. The specialist clinic has also meant that I can take in other aspects of PKD, looking at kidney size and suitability for transplantation, a good family history for aneurysms, making sure patients are educated about prompt treatment for urosepsis, and pain review. Interestingly, pain is something as those kidneys grows is increasingly problematic, and many patients have asked for referrals to alternative treatments such as Reiki and the Alexander technique, which would be much better compared to me doling out analgesics. We've also been able to educate our radiologists in kidney volume assessments, and it's been extremely helpful for a period. So I think, with time running out, this used to be a very, this is the House of Parliament in London, used to be looked on around the world as being rather proud of. I don't think we are in 2019, but hopefully it will come back next year. Thank you for your attention.